All right, so let's jump right in. I know you guys are all busy prepping for those huge exams, FRCS and all that. So we're going to make this deep dive count today, and we're going to be tackling a topic that I am certain you're going to get asked about, and that is surgical approaches to the spine. And to guide us through this, we've got some fantastic notes called Ortho Made Simple, and these are from mokyingren.sg. They're put together by Dr. Mok Ying Ren, who's a sports surgeon from National University Hospital in Singapore, and he aced his FRCS back in 2022.
Excellent notes, especially, I think, for the practical aspects of it.
Yeah, absolutely. And today, we're going to focus on, the key things that you'll need for those exams, whether it's FRCS or equivalent. So let's start with the cervical spine, the anterior Smith-Robinson approach. What are the standout points there?
Well, the first thing that really jumped out at me when I was looking through these notes was just the emphasis on meticulous preparation. It's like setting the stage for a performance.
Makes sense. Spine surgery. It's all about precision.
Yeah, absolutely. You're working around such delicate structures that every step has to be deliberate. And think about it. Patients' supine sandbags, carefully placed, head tilted just so. Even taped down for stability. It all matters.
I'm curious about those seemingly small things. Like, why is shoulder strapping so important? I wouldn't have thought that would make that much of a difference.
It's all about getting the best view possible. So you pull those muscles out of the way, giving you a much clearer shot at the cervical spine.
Ah, so it's like setting up the perfect camera angle. I like that. Now, what about localizing those cervical vertebrae? Any tips for remembering the levels?
Well, this is where those mnemonics come in handy. Remember, he was using everyday landmarks, hard palate C1, angle of the jaw C2.
Right, and hyoid C3, like an HTC phone. I love it.
Exactly. And then you've got thyroid cartilage, C4, C5, and then cricoid at C6.
Clever.
So it really helps you orientate yourself quickly, which is, what you need in the OR.
Okay, landmarks checked.
Yeah.
But now we're not in the clear yet, right? The neck is full of these danger zones. How do we navigate those?
Yeah, I think he explains this really well. Think layers. You're working through layers of tissue, each one with its own set of critical structures.
Right.
So starting with the platysma, you've got to be mindful of the external jugular vein.
Right, got to be careful there.
Yeah.
What about the next layer down?
Then you hit that pretracheal fascia. That's where you got to watch out for the superior and inferior thyroid arteries.
And then comes the big one, right? The tracheoesophageal groove, where that recurrent laryngeal nerve is hanging out. I can practically see that exam question now.
Oh, you bet. Damage to the RLN, major complication leading to vocal cord paralysis. And then as you go even deeper along the longest colline muscles, you're running into the sympathetic chain.
Don't want to mess with that.
No, you don't.
Okay, so navigating these layers, it's a high-stakes game of operation. But let's say we've done all that. Got our landmarks, we've dodged the danger zones. Now we're actually starting the surgery. What are the key steps in dissecting for this Smith-Robinson approach?
So again, it's systematic. You make that horizontal incision, you carefully split the platysma, and then it's all about identifying the sternocleidomastoid muscle. That's your guidepost.
And then we go deeper.
Right. You incise the deep cervical fascia, retract those strap muscles medially, and then carefully identify the carotid sheath. It's like a delicate dance moving these vital structures out of the way to reach the spine.
So much to keep track of. It's amazing how much knowledge goes into each step.
It is, and you're not done yet. You have to deal with the prevertebral fascia before finally reaching the anterior surface of those vertebral bodies. And of course, retractor placement is crucial to protect the sympathetic chain.
Remember that warm red foot we talked about?
Right, but it really underscores the importance of knowing your anatomy and proceeding with caution.
Absolutely. Now, before we move on from this approach, I got to ask, left side or right side? Is there like a preferred approach?
He mentions the left side being a bit safer because that RLN is more predictable there. But of course, many right-handed surgeons find the right-sided approach a bit more comfortable. So it's a balance of factors.
Makes sense. Now, before we move on to the lumbar spine, I'm flashing back to that high C-spine warning. What's the big concern up there?
You're thinking about the hypoglossal nerve. It becomes particularly vulnerable in those high cervical approaches. And if you damage it, well, you end up with tongue deviation. Not a fun conversation to have with your patient post-op.
Definitely not. Okay, on that note, let's shift gears and head down to the lumbar spine. We'll be right back after a quick reminder that today's deep dive is based on the Ortho Made Simple notes, which you can find at mokyingren.sg.
Okay, lumbar spine. Now, one of the big ones you'll need to know for your exams is the posterior approach.
A classic for a reason, right? Seems like bread and butter for a lot of spine surgeons.
Absolutely. But before we even think about making an incision, we need to talk patient positioning. I mean, Dr. Moore really hammers this home, and for good reason.
Yeah, protecting those nerves is paramount. It's all about minimizing risk, especially when you're prepping for those big exams.
Exactly. So let's break it down. What are the key nerves at risk during a posterior lumbar approach, and how do we protect them? Think you can remember those 5 nerves.
Yeah, let me see. Well, we got to protect the eyes. So I'm guessing orbital padding for that supraorbital nerve?
Spot on. What else?
Elbows need protection too, right? So we're talking ulnar nerve, padding around that medial epicondyle.
Perfect. 3 more to go.
Okay, sciatic nerve. We keep those knees bent. That should help reduce tension, right?
You're on a roll. What about the lower limbs?
More padding, I'm sure. Let's see, we need to protect that femoral nerve and the lateral femoral cutaneous nerve. So padding at the ACIS, those bony prominences on the pelvis.
Excellent. And last but not least, what about the abdomen?
Ah, yes.
Mm-hmm.
We can't forget about Batson's plexus. The abdomen absolutely has to hang free to prevent venous pooling in that valveless system.
Nailed it. You see, you got this. Knowing those 5 nerves and how to protect them is key for the exams and, of course, for real-life surgery. Now let's talk tables. He mentions both the Jackson and the Wilson frame. What's the difference, and why does it matter which one we use?
Well, from what I recall, the Jackson table allows for lordosis, that natural inward curve of the lumbar spine. And it's also good for procedures where you might need to flip the patient right.
That's right. The Jackson gives you that 360-degree access if you need it. The Wilson frame, on the other hand, is all about widening that interlaminar space, particularly useful when you're coming at anterior pathology from a posterior approach.
Got it. So the choice of table really depends on what you're trying to achieve surgically.
Yeah.
Now let's dive into that dissection. What's the first step in a posterior lumbar approach?
Start nice and straightforward midline incision right over those spinous processes. Then you incise through the lumbodorsal fascia and carefully detach those paraspinal muscles, the multifidus, longissimus, and iliocostylis. We do this superiostally as one unit working laterally up to the facet joints.
Why superiostally? What's the advantage there?
It minimizes bleeding for one, and it helps preserve those muscle attachments, which means a smoother recovery for the patient.
So less trauma overall. Makes sense.
Yeah.
So now that we've cleared a path, we can either do a laminotomy or laminectomy depending on what's planned. But before we get into the specifics of those, let's talk about some variations on this posterior approach.
I see he mentions the Wiltse approach. What's different about this one?
The Wiltse approach is all about minimizing muscle disruption. So instead of that midline incision, you're going in about 3 centimeters lateral to the midline. And instead of detaching those muscles, you use a muscle splitting technique going between the multifidus and longissimus.
Interesting. So it's a less invasive approach overall, which I imagine translates to less pain and faster recovery for the patient.
Exactly. Minimizing trauma is always a win, both for the patient and for you as the surgeon. Less to worry about.
Right. Now, we've talked a lot about posterior approaches, but what about those times when you need to access the spine from the front? What can you tell us about anterior lumbar approaches?
Anterior approaches are a whole different ballgame. They definitely have their place, but they come with a unique set of considerations. I bet. It's a whole different anatomical landscape when you're coming in from the front.
Yeah.
So when does it make the most sense to choose an anterior approach?
Well, think about those big vessels, the aorta, the vena cava. You don't want to be messing around with those higher up in the lumbar spine, right? So the sweet spot for an anterior approach is typically L5S1.
Okay, so L5S1 is the go-to for anterior. But I see he talks about 2 types, transperitoneal and retroperitoneal. What's the difference?
It all comes down to how you reach the spine. So in the transperitoneal approach, you're going right through the peritoneum, that membrane that lines the abdominal cavity. Think midline incision or a Fannin steel if you're working at L5S1. You're literally going through the belly.
Wow, that's direct. What about the retroperitoneal approach? You still have to go through all those layers?
The retroperitoneal approach is a bit more roundabout. You're still working in the same area, but you're staying behind the peritoneum. Instead of going through it, you're carefully dissecting your way through the retroperitoneal space.
So it's like taking the scenic route, avoiding those major abdominal structures.
Exactly. It's a bit more work, but it can be a safer option in some cases.
So 2 different paths to the same destination, the anterior lumbar spine. But why go through all that trouble? What are the advantages of an anterior approach?
Well, you get some distinct advantages when it comes to disc space clearance and end plate preparation. You have more room to work, which means you can maximize implant size and get better correction of lordosis.
So it's all about optimizing access and achieving better correction. That makes sense. Now, he also mentions this anterolateral retroperitoneal approach. What's the story with that one?
The anterolateral retroperitoneal approach is a great option for accessing the lumbar spine from the side. It gives you a direct route to the disc space without having to worry about the bowel, which is always a plus.
I'm all for less bowel handling,
Okay.
less risk of complications there. So how do we position the patient for this approach?
For this one, the patient is positioned laterally lying on their side. You can even use an AMSKO table, which has that break in it, to further enhance your access to the spine.
Ah, yes, the AMSKO table. We'll have to add that to our list of tables to know for the exams. What about the incision? Where are we cutting for this anterolateral approach?
The incision starts around the 12th rib and then extends obliquely towards the lateral border of the rectus abdominis muscle, about 5 centimeters lateral to the midline. It's all about those anatomical landmarks guiding your way.
It's like following a map, right? And then, of course, there's the deep dive into anatomy as you dissect down. What are the key layers and structures we encounter here?
You'll hit those familiar abdominal muscles, the external oblique, internal oblique, and transversus abdominis. Then you'll hit that key plane between the retroperitoneal fat and the fascia over the psoas muscle.
Psoas? Always good to see a familiar friend in surgery.
Right, absolutely.
Yeah.
You carefully sweep everything anteriorly to expose the psoas. And then you need to ligate those lumbar vessels branching off the aorta. This lets you safely mobilize the aorta and gives you more room to work.
Okay, psoas exposed, aorta mobilized. Now we're ready to talk about the main event, lumbar fusion approaches. This is where things get really exciting. We're talking about procedures designed to stabilize the spine, often using bone grafts and instrumentation.
Exactly. He kicks things off by describing a posterolateral fusion, or PLF, both with and without instrumentation. Can you explain the basic idea behind a PLF?
Well, from what I understand, the goal of a PLF is to create a fusion between the transverse processes of adjacent vertebrae. We traditionally use a bone graft to act as a bridge, encouraging those bones to fuse over time. But what about when we add instrumentation? How does that change things?
Instrumentation, typically in the form of screws and rods, adds that extra level of stability to the fusion. It helps hold everything in place while that bone graft is doing its job. Think of it as the scaffolding supporting the bone bridge as it forms.
That's a great analogy. So instrumentation provides that immediate stability, which is especially important in cases with a lot of instability or deformity.
Exactly. It's a powerful tool in the spine surgeon's arsenal.
Now moving on, he delves into two other common fusion procedures, PLIF and TLIF.
Yeah.
What do those acronyms stand for, and what are the key differences?
PLIF stands for posterior lumbar interbody fusion, while TLIF stands for transforaminal lumbar interbody fusion. Both involve placing a bone graft or an implant into the disc space between two vertebrae, but they differ in their approach and access points.
Okay, so it's all about how you get to that disc space. Walk me through it.
In a PLIF, you're performing a laminotomy, which is removing a portion of the lamina medial to the facet joint. Your focus is on accessing that disc space from a medial approach.
So you're coming in from the middle, right next to that facet joint. But what are the downsides of this approach?
One of the main drawbacks is that you often need to retract those nerve roots significantly to get to the disc space, and that increases the risk of nerve injury. You're also working very close to the dura, so there's a higher risk of a dural tear.
Those are some serious risks.
Yeah.
That's where TLIF comes in.
Exactly. TLIF was developed to address those concerns. It's a less invasive approach, minimizing that nerve root retraction. So instead of a laminotomy, you're doing a unilateral laminectomy, taking out the entire lamina on one side, along with a facetectomy, removing the facet joint. This gives you better visualization and access to the disc space without having to retract those nerve roots as much.
So it's a bit more roundabout, but gentler on those nerves. I can see the appeal. Now, in addition to PLIF and TLIF, he mentions XLIF, OLIF, and ALIF. Can you give me a quick rundown of those?
Absolutely. XLIF, or extreme lateral interbody fusion, is all about accessing the disc space from the side using a lateral retroperitoneal transfoas quarter. It's a minimally invasive approach that's great for levels T12 to L5.
So you're going through the psoas muscle, bold move.
It is, but there's a catch. XIF isn't suitable for L5S1 because the iliac crest gets in the way.
Anatomy always has the final say. What about OLIF?
OLIF, or oblique lumbar interbody fusion, is similar to XLIF in that it's a lateral approach, but instead of going through the psoas, you're working anterior to it. It's also known as the anterior retroperitoneal approach.
Got it. So another option for coming in from the side. And finally, AO. What's that all about?
ALIF stands for anterior lumbar interbody fusion. It's essentially that transperitoneal approach we talked about earlier, where you go through the abdomen to access the spine from the front.
Okay, so we've got a whole arsenal of fusion approaches, each with its own advantages and limitations. It's like a toolkit for spine surgeons. Before we wrap up this section, I want to touch on a few miscellaneous things he covers in his notes. First up, Skyne tables. We already talked about Jackson and Wilson. Any others we should know for the exams?
He also mentions the AMS-KEO table. Remember that one? It's a pretty versatile table that allows for all sorts of positioning options.
Right, like that jackknife position for lateral approaches.
Exactly. And it can be used to open up that interlaminar space in the prone position too, which can be helpful for some posterior approaches.
So the AMS-KEO table is all about versatility and maximizing access. Got it. Now let's move on to a structure that always trips me up, the ligamentum flavum. Can you remind me of the anatomy and tell me how to do a flavectomy?
Sure. The ligamentum flavum is that strong elastic ligament that connects the laminae of adjacent vertebrae. It helps stabilize the spine and prevents too much flexion. Now, a flavectomy is the surgical removal of this ligament, and it's often done during spinal decompression procedures to create more space for the spinal cord or nerve roots.
Right, so we're taking out that ligament to relieve pressure on the nerves.
Yeah.
But can you remind me where exactly this ligament is located? I always struggle with visualizing it.
Think of it like this. The ligamentum flavum spans between the laminae like a bridge.
Oh.
Superiorly, it arises from the ventral surface about halfway up the craniolamina. Inferiorly, it attaches to the leading edge of the inferior lamina. Medially, no attachments, but laterally, it extends to the medial border of that inferior articulating facet.
Okay, I'm starting to see it now. So how do you actually perform a flavectomy?
There are a couple of ways to approach it, either superiorly or inferiorly. I prefer to start by freeing up the inferior edge of the ligament from the inferior lamina using a blunt curette.
So you're gently detaching it from its bony attachment.
Exactly. Then I use a Carotson rongeur to remove the distal end of that superior lamina, which exposes the attachment of the ligamentum flavum.
Got it. So gentle detachment, then careful removal with the rongeur.
Precisely. You want to be very methodical as you're removing the ligamentum flavum. Precision is key here. You don't want to damage anything around it.
Right. Gentle and precise. Those are the watchwords. Now, before we move on to that TLIF sequence, I want to talk about something that's super important, both for exams and for real-life surgery, the risks of anterior and lateral lumbar surgery.
Absolutely. It's not just about knowing the steps, it's about understanding the potential complications. He has a great way of remembering the key structures at risk. He calls them the 4 things on the psoas.
Oh, I love a good mnemonic. Hit me with those 4 things.
First up, we have the ureter, which lies right on top of the psoas muscle. To identify the ureter during surgery, you can gently stroke it and look for peristalsis, that wave-like contraction that moves urine through.
Okay, so always be on the lookout for the ureter. What else?
Next, we have the genitofemoral nerve running along the anteromedial surface of the psoas. Damage to this nerve can cause numbness or pain in the upper anterior thigh and the scrotum.
2 down, 2 to go.
The third thing on the psoas is the sympathetic chain running along the medial border of the muscle. Disrupting the sympathetic chain can cause a warm red foot on the same side as the surgical approach.
Hold on, a warm red foot. That seems counterintuitive.
It does seem odd, but it makes sense when you think about it. The sympathetic nervous system normally causes vasoconstriction narrowing of those blood vessels. So when you disrupt the sympathetic chain, you get vasodilation. The blood vessels widen. That leads to increased blood flow to the foot, making it warmer and redder.
Wow, that's a good one to remember. What's the last of the 4 things?
The fourth, and perhaps most dreaded, is the risk of retrograde ejaculation. This is due to potential injury to the superior hypogastric plexus, which sits right in front of those lower lumbar vertebrae.
Yeah, retrograde ejaculation is definitely not a complication you want to have to explain.
Absolutely not. And it's important to remember that these are just some of the potential risks. We also have to think about vascular injury infection and even wrong level surgery.
Right. So many things to be mindful of. Okay, I think we're ready for the grand finale of this section, the TLIF sequence. Take it away.
All right, let's walk through a TLIF from start to finish. First, you insert those pedicle screws, which are going to act as anchors for the rods. They're like the foundation of the whole construct.
Makes sense. So screws in, what's next?
Next, we're preparing that interbody space, the space between the 2 vertebrae where the bone graft or implant will go. This involves distraction, facetectomy, and flavectomy.
Okay, let's break those down one by one. What's distraction all about?
Distraction is essentially creating more space between those vertebrae. You can do this by pushing those spinous processes apart, which gives you more room to work.
So it's like gently stretching out the spine.
That's a good way to think about it.
Yeah.
Once you have enough distraction, you perform the unilateral facetectomy, removing that facet joint on one side.
And then we're back to the flavectomy. Right, removing the ligamentum flavum.
You got it. We remove the ligamentum flavum to further decompress the spinal canal and create even more space for that bone graft or implant.
So we've crept the space. What comes next?
Now comes the crucial step of preparing those end plates, the top and bottom surfaces of the vertebral bodies. You need to prepare them carefully to create a good surface for the bone graft or implant to fuse to, but you also want to preserve their integrity as much as possible. It's a delicate balance.
It's all about finding that sweet spot, creating a good fusion surface without damaging the bone too much.
Exactly. Once those end plates are prepped, you can insert the trial cage or implant, making sure it fits snugly in the disc space. And then comes the final step, placing the rod and reducing everything into its final position.
So we're connecting those screws with the rod, locking everything into place.
Precisely. And with that, the TLIF procedure is complete.
Wow, what a journey. We've covered so much ground in this section, from anterior approaches to all sorts of fusion techniques. And it's all thanks to those brilliant ortho-made simple notes, which you can find at mokyingren.sg. Be sure to check them out if you haven't already. Okay, we're back. We made it to the final stretch of our deep dive into spine approaches. We've covered a lot of ground cervical, lumbar, posterior, anterior, you name it.
It's been quite a journey through the world of spine surgery. And the best part is all of this knowledge is coming straight from those ortho-made simple notes available at mokyingren.sg.
Absolutely. Those notes are a lifesaver, especially for residents like you gearing up for those big postgraduate exams. So as we wrap things up, let's take a step back and think about the big picture. What are the key takeaways you want our listeners to walk away with?
Well, I think the first thing that really stands out is the importance of meticulous preparation in spine surgery. Whether it's positioning the patient, knowing your anatomy inside and out, or planning your approach carefully, every detail matters. It's all about minimizing risk and maximizing those outcomes for our patients.
Right. And speaking of minimizing risk, we can't forget about those 4 things on the psoas. Those are crucial to remember, not just for the exams, but for your surgical practice as well.
Absolutely. The ureter, the genitofemoral nerve, the sympathetic chain, and the risk of retrograde ejaculation. These are potential complications that can arise during anterior or lateral lumbar approaches. Knowing those structures and how to protect them is essential.
It's like having a mental checklist every time you approach the spine.
Exactly. And let's not forget about those anatomical landmarks. They're like signposts guiding you through the surgical field. From the hyoid bone at C3 to the psoas muscle in the lumbar spine, knowing your landmarks is key for safe and effective surgery.
It's amazing how much those little details can impact the success of a surgery, and it highlights just how important it is to have a strong foundation in anatomy.
Couldn't agree more. It's the bedrock of everything we do as surgeons.
Now, beyond those foundational elements, we also explored the nuances of different surgical approaches: PLIF versus TLIF, transperitoneal versus retroperitoneal. Each approach has its own set of advantages and disadvantages, and choosing the right one depends on the specific patient and the pathology you're dealing with.
That's right. There's no one-size-fits-all approach in spine surgery. It's about carefully considering the individual patient's needs and tailoring the procedure accordingly.
It's like having a toolbox full of different instruments. You need to know which tool is best for the job at hand.
Precisely. And that's where experience and judgment come into play. But having a solid understanding of the different approaches is the first step.
Well said. We've given our listeners a lot to think about today. And remember, this is just a taste of what Dr. Mok's ortho-made simple notes have to offer. I highly encourage everyone to check out his full notes at mokyingren.sg. It's a goldmine of information, especially for those prepping for their exams.
Absolutely. He's done a fantastic job of breaking down these complex concepts into digestible pieces, making it easier for residents to learn and retain this information.
And as you continue your studies and prepare for those challenging exams, I want to leave you with this thought. Don't just memorize the steps. Think critically about the why behind each approach. Why is this approach preferred in this situation? What are the potential risks and benefits? Asking those questions will deepen your understanding and make you a better surgeon in the long run.
Great advice. And remember, spine surgery is a constantly evolving field. New techniques and technologies are always emerging, so it's crucial to stay curious, keep learning, and never stop challenging yourself.
That's a wrap on our deep dive into spine approaches. Thanks for joining us, and best of luck with your exams.